live.
Good afternoon, everybody. My name's Ian Turner. I'm chair of the Registered Nursing Home Association and a provider of care homes in East Anglia myself. Welcome to this webinar on data sharing across integrated care systems. My co-chair Ming Tang has been delayed for a little bit, so I'm actually going to start and Ming's going to actually join us very shortly. First of all, I very much welcome this opportunity to co-host this event with NHS England. We are at the start of a journey with the integrated care systems, with the opportunity to uniquely improve the quality of care that we provide to our local populations. I'm sure Ming is going to say far more about that than I will. But I just want to take the opportunity firstly to talk to some of the NHS people who may not be as knowledgeable about how social care is organised and structured as we attempt to actually provide more data sharing across the system. The main thing I want to say is that there's only 2% of social care providers have more than 250 staff. And consequently, they are small businesses providing either home care services or learning disability services or small care homes. And typically they'll have 3 managers in there, a registered manager, a deputy manager of some sort, and an administrator. And those 3 people have to do everything for that service. So their ability to manage change in those organisations is very limited. And consequently, what we've ended up with in terms of cybersecurity, for example, which I'll come back to in a bit, is that we have a national team that can actually support them. And then we have local support organisations that can work with you within ICSs and within local authority areas to actually help providers in that locality to actually achieve whatever we're trying to achieve. Now, a number of these things went into overdrive during the pandemic, as most of you will be well aware, and things like the adoption of NHS Mail suddenly shot through the roof. The point is that we're seeing a similar sort of thing happening at the minute on digital care records, where we think we're somewhere around just over 40% of care providers, even though they are relatively small, have now adopted digital care records. Now, that in itself gives us problems doing data sharing, predominantly because we are using different software to our local authority colleagues, and certainly we're using different software to NHS systems. So what we're actually trying to do is make sure that we move from clerically collecting data, which is what we were doing during the pandemic, to actually using interoperability to be able to automatically share data across the system. Now, of course, to do that, we need all our providers to be what we call in our sector accredited. In other words, they've signed up to being to participating in pilots and actually providing facilities in their software that enable us to do that. And the first step of doing that was, of course, to actually look at the standards for that data. What are we actually going to store? What are we going to share? What format should it be in? And how are we going to actually manage it? Now, that all takes me around to how are we actually going to do it? And to do that, what we're trying to achieve is to get to the point where all our suppliers have signed up to that accreditation, or the major ones at least, and consequently we can add functionality to the software that we're using over the next few years to enable us to actually achieve that interoperability. But can I pull back from the technology bit and actually look at, well, why are we doing this? And basically why we're doing it is that we want to make sure that people's experience of the health and care that they receive is a positive experience. So to give you a couple of examples, one is the Alzheimer's Society This Is Me standard. which is something that we actually need to share regularly and across all the sector to make sure that everybody is addressed in the way they want to be addressed, that they're provided with food and drink that they actually prefer, and that all of us, wherever we're offering service, can actually use that particular standard. A historical one that I'll just drop in is a situation with the acute providers, where my brother was actually a patient of an acute trust under 4 different consultants at the same time. He got extremely fed up of having to tell each of those consultants what all the other 3 had said and repeat every time what the issues were. He was absolutely delighted when that particular trust put in a system that allowed each consultant to see his record in total. And it had a significant effect upon the service that he received on it from that acute trust. Next thing I want to basically major on is the word partnership, because we cannot, in my view, achieve data sharing without us being in partnership with each other. Primarily, that's because the word partnership actually means risk. It means sharing risk across the system. And one thing's guaranteed with technology: we won't actually get it right first time every time. We'll have to iterate, we'll find things that we want to change, and we want to get to the point where we've got the flexibility to do that. So one of the absolute fundamentals that we want to do is to try and make sure that at a local level and at a national level, we've got the right partnerships, we've got the right relationships with people wherever they are in the system, whether they're in the local authority, whether they're in the smallest care provider, or whether they're in one of the local NHS ICSs. And it's that I want to actually recommend to you, that you have a look at the document that was published this morning about cybersecurity, because that document actually has built into it the fact that we've got a very different structure in social care between all those small providers than you have in the NHS, even at ICS level. And it actually acknowledges that we're all starting at a different point and actually need to move towards having a more integrated way of working. Okay, that's the majority of things that I wanted to say to open up. Is Ming available yet, or are we going to actually move over to Rachel?
I think we'll go straight over to Rachel Power, please, Ian. Okay,
so thank you, Rachel Power, who's going to give you the patient's experience.
Thanks so much, Ian, and thank you so much for inviting me to come here. So, and actually, I'm going to talk about partnership too, Ian, and I'm going to talk about partnership with between health and social care, but also with patients. So I'm Rachel, I'm the Chief Executive of the Patient Association. If we can just go on to the next slide, please. So the Patient Association is an independent patient charity. So we're pretty small. We're a membership organisation. We're a free membership organisation. So we're made up of patients and people and the public who are really interested in health and care, and want to work with us to make sure that there is patient partnership in design and delivery of services, so that everybody can get access to the health and care that they need to live their lives well. We do a range of different pieces of work to do that, and I'm just, before I go into the presentation, if we just go on to the next slide, please. So we run a helpline, and it's a national free phone helpline, and that runs from 9 to 4:30 Monday to Friday, and we get a range of different calls on there, and we get a lot of calls about accessing medical records, which is the very start of data, and wanting to have access to all their medical records. We get a lot of calls about wayfinding around the health and care systems, and what people, sometimes carers, an increasing number of safeguarding calls, which are very much related to care, to social care as well as healthcare. We run a lot of paid projects. We get commissioned by NHS England. We get commissioned by a range of different organisations to run different patient-focused pieces of work. So one of the pieces of work that we're just about to start, which is around the data pact, and really hearing from patients about what they want to be as part of that data pact, which was promised in the data strategy that the department published back when Sajid was the health secretary. We use our patient voice and we use all our membership to find out what patients are thinking about issues that are going on, so that we can do social media, so we can do kind of policy consultations, and we engage with a lot of organisations around smaller patient groups to make sure that we're hearing those voices too. And we do a lot of work with people who are at risk of health inequalities. And I think one of the things with data sharing and the importance of the work that ICSs will be doing around data sharing is really making sure that we use, Ian, you kind of referenced it in using acronyms for NHS, and we've got social care staff on here, but actually if we're going to talk about data, let's make sure we're speaking in accessible terms so that patients, all patients, we've got a health literacy age of 9 to 12, and let's make sure that all patients understand what we're talking about when we're talking about data sharing and why data sharing is such a good thing. I also chair a digital coalition, which is a group of charities and Royal Colleges that's looking at the digital transformation that's happening and making sure that patients are very much at the centre of all this new work around data and data sharing. So if we pass on to the next slide. So I'm not going to read these slides out to you because there's quite a bit of information on here, but at the beginning of the pandemic, we started to look at our strategy. I'd just been with the organisation for a couple of years and we'd done a little bit of work on the strategy, but we started to look at actually what's happening, what's life going to be like post-pandemic, what's health and care going to be like post-pandemic, and we started to look and say, well, actually, if we are going to share the risk, like you talk, Ian, about, is actually how do we have that partnership with patients? I hope everyone can hear me okay, because there's been a problem with my mic earlier on. Brilliant, just thought I'd check. So we're starting to put together, we do a lot of work with ICSs, just done a huge project with Hearts ICS around the patient participation group and how to involve them. So we're pulling together what the characteristics, we started to look at patient partnership and we were like, there is absolutely so much guidance in health and care about how to do patient partnership and what should happen and shared decision making and all of those, but actually it's not happening on the whole for patients. So we thought we would use those principles that are already there and design new principles that we've tested with local leaders, and we've tested with patients, obviously, and we've tested with the regulators, and we're now at the stage of defining actually what needs to be in place for patient partnership to happen well in health and care. So, and I know I'm talking about patients here, but we are the Patient Association, and we did talk to our members a lot about what they wanted to be, what they felt. So, when I talk about patients, forgive me, it is about service users, it is about residents, it is about, people accessing services, it's about people and communities. So it's about being treated as equally and having an equal say in their decisions. And in the next couple of slides, I'm going to tell you about a piece of work that we did with the University of Manchester, which I think is really important to the conversation that's happening today. And I'm really grateful to the team, because actually it's really nice to see the patient's view being at the top of the agenda, because quite often I'm most definitely not at the top of the agenda. I'm quite often when the trains have been booked. So, that whole thing about being fully informed, and what I talked about earlier about that accessibility of language and the way that we speak. I've spoken to you about shared decision making and patient partnership. There is evidence out there that if we do this well, it will have a better outcome for patients. It'll be more motivational for staff, which is really important right now, and it will be a safer system. The whole thing around inequalities and health inequalities is just so important to recognise. These are not new things. They have been around for years. There's people among you that mightn't have read Professor Michael Marmot's reports. You know, he did one just before the pandemic, which was 10 years on from his first report. And if we really want to engage people and get them to understand data and why data sharing is important, we've really got to understand inequalities as well. I think the bit about patient input I've gone on about, and those services being joined up around patients, and you know the need for health and care to work together, which is what Ian has talked about, and patients in there, but making sure that we're all working together. You know, the amount of stories we hear about people trying to get their loved ones out of hospitals and, you know, delayed discharges, all of those things. But, you know, let's work together on that. So if we move on to the next slide, please. So whilst this piece of work was very much related to the GPDT, the General Practice Data Trust that was launched a couple of years ago, I think the principles that we go on to are about any level of data sharing, and I think they fit quite well. So we held focus groups. We held focus groups with people who really understood the General Practice Data Trust, and we held focus groups and had opted in, and we held focus groups with people who'd opted out to try and see why this stuff is happening. And this is backed up by a larger report that the University of Manchester will be publishing a bit more on in the next few weeks. In terms of the individual interviews and a lot of the academic literature reviews that they did, but this was very focused on what are patients saying. So if we just go on to the next slide, please. So it goes without saying that they want full access to their medical records, and on our website is now a webinar that we did last week with 2 patients at NHS England on accessing medical records and why people found it really helpful. But that's the individual shared decision making part of it. What they want is information and transformation. They want to understand what is being done with their data. They want control over their data, and they want assurance about the technical quality of the data handling and the strong data protection. And Ian, I think you referenced the cyber policy that's come out today, which, you know, is obviously welcoming. Some of this will be welcomed by a lot of patients. There was an issue, and it did come up, that there was still that concern about the use of private or profit-making companies in using their data and the data being passed on to those, even where the data being used might actually help. So that there's more work that we need to do there together to try and really understand and drill down into that a little bit more. But it's about patients feeling they have the power over their data and how their data is used. And so if we go on to the next slide, please. So as a result of the focus groups, we've issued a report which is on our website. I can put a copy of it in the chat as well. And in there, what are recommendations? Now, these recommendations were very much the NHS, but I think they cross the partnership between health and care. You know, patients' trust has been significantly undermined. You know, we've got the deep mind to all the issues where it didn't work well and it wasn't planned well, has left people feeling that trust is not there. And there needs to be humility. We need to show that we got it wrong and we've learned why it went wrong and what we're going to do to make sure that that doesn't happen again over data sharing. As partners in health and care, we must really consider how to secure broad-based consent for any future data sharing initiatives. And I left this one as the NHS because I think this one is the NHS, and this is about how do we raise the public awareness and information campaign that shows patients how we use their data, why we need to use data, and how data is used safely, and actually how is it used to improve health and care outcomes for all patients, service users, people and communities, and how does it move us forward, and how does it make the service that we end up receiving individually a more effective and more efficient service. So if we move on, I'm mindful, I think I've got 1 minute left. So, you know, for the beginning, it might be that that more awareness might cause people to actually withdraw, but actually that's okay, because we work with people to get them to understand why we're sharing data, and we can turn that around. And then I think, you know, the future data, the Federation data platform, everything else needs really to maximise patients' individual insight and control of their data. And to enable them to see each use of their data and to withhold permissions, which we addressed in earlier slides. So, you know, where people really genuinely don't want it to be shared with private or profit-making companies, then that is a right that they have to hold that back. So, I think that is the end of my slides. Is it, or do I have? So, obviously, I'm going to sell the Patient Association while I'm here, so more information there on our website, because there's a lot of different reports, and on there at the moment is our newest report, which is the outcome of our recent patient experience survey, which does talk a lot about information and communication, so it might be of interest to colleagues on here. And I think I'm around to ask any questions later, maybe. Thank you so much for listening to me. And now I think I am passing over to Deb and Natalie.
Yes, that's right. Thank you. So thank you everyone for inviting us along today. I'm Deborah Jen. I work for Lancashire County Council half the week, and I also work for the Integrated Care Board the other half of the week. And I'm here with my colleague, Nat. Nat, would you like to introduce yourself?
Yeah, I'm Natalie Heaven. I'm the subject matter expert for the team, but I'm also a registered care manager for a care home as well.
Okay, so I could just move on to the first slide, please. So this is a little context about Lancashire and South Cumbria. So we're quite big. We cover 7,000 square kilometres, and we're in the northwest of England. We have a population of 1.8 million, and we've got quite a lot of GP practices. You know, a lot of residential and nursing homes, a lot of domiciliary care agencies, and we've got a large regulated care market. You know, with nearly 90,000 people working in health and social care across our region. So we cover quite a big patch, does our little team. So we can go on to the next slide, please. So we have developed this roadmap, and this is our journey that we're going to take our adult regulated care providers on. So our team works with our domiciliary care agencies, our care homes, our supported accommodation providers, our extra care providers as well, and we help them on the digital journey. Stage 1 is all about making sure they have the skills and the knowledge to become digital. Stage 2 is making sure that they have that infrastructure in place, you know, to work in a digital way. So it's that wireless connectivity. It's making sure that they have, you know, all the infrastructure there ready to do that. Stage 3 is about making sure that they are working online safely. So it's making sure that they are compliant with the Data Security Protection Toolkit, the DSPT, making sure they have active NHS mail accounts and are using them, and have the right policies in place. And stage 4 is our goal. That's when we're all creating and consuming data in that shared care record. That's our ultimate goal. And what we're doing, we're helping our regulated care market to be in a better position to do that in the future. We're not there yet, but that's our goal, and that's the journey that we're on in Lancashire and South Cumbria. And underpinning all of that is making sure that all our staff have the right knowledge, the skills and the competencies to work in the digital world. So could I pop up to the next slide, please? So like I said, we're only a little team. There we are on the left. There's not many of us. And most of us are part-time. There's only one full-time staff member. So we've got representatives from, you know, health, from the council, you know, I'm Natalie from a local care home. And together what we're doing, we're working on proxy access, we're working on secure mail, the DSPT compliance, the the digital capability of the workforce. A big piece of our work is making sure that people are moving, our care providers are moving from paper to electronic care records. So that DSCR is that digital social care record and the implementation of those. And we're also rolling out sensor-based falls technology across our care homes. We have great support from our regional digital social care lead, but we're a small team that works pretty hard over a big area. So could I have the next slide, please? So we started the process back in July 2021, and we first submitted our bid actually in June 2020, when we put in our first application for some funding to help our regulated care providers move from paper to electronic care records. And we got at first £50,000, and we've supported with that money 5 care homes to move from paper to electronic. We learned a lot, and we'll tell you about that later on, but gosh, did we learn so much in that early days. We then got our next set of funding from the Unified Tech Fund, and we've supported another 40 care homes to move from paper to digital. And we're in our next stage now where we've got money from the Digital Transformation Fund, and we're currently working with 85 care homes and some domiciliary care agencies to move them from paper to electronic care records. So can we move to the next one, please? Now, we know that there are a lot of benefits to moving from paper to electronic, and I'm not going to go through all of these because it's a very busy slide, and I put these on so you can look at them at your leisure. But over on the left-hand side, you'll see that there's a lot of benefits for the individuals in receipt of care, our providers, the NHS, the local authorities, and the regulators. So it streamlines processes, it frees up time, staff capacity in the care home. It's efficient in terms of we're not chopping down as many trees, and it really helps with CQC compliance. But there are so many benefits, and this busy slide tries to reflect all the benefits that there are in moving from paper to electronic. And we're starting to see those now as our initial sites are fully implemented and starting to reap the benefits of moving from paper to electronic. So can I move on to the next slide, please? So when we first set up 18 months to 2 years ago, we set up a really strong governance structure because we thought that was really key to our work. So we're governed by a steering group, and we meet monthly. And our steering group consists of our DAS, our Director of Adult Social Services, 2 senior health leads, 4 local authority leads, and the Digitising Social Care team. The steering group reports into the Adult Social Care and Health Partnership Board every 2 months, and we work with the Local Government Association, North West ADAS, the Care Provider Association, and the individuals receiving care to ensure we deliver the project objectives. Can I move on to the next slide, please? So we have a process of moving from paper to electronic care records. It's a journey that we take all our care providers on. Overpinning all of this is the communication. So we want that great communication across it. But what we do, we take them on a journey from researching what system they would like, to procuring it, to implementing it. And we give them a lot of tools to do that. So we show them the assured provider list. We get them to use the decision tree, which is a national tool, so it helps them decide what sort of functions and functionality they would like out of a digital social care record. And this helps them choose the most appropriate supplier. We give them demos, we have videos that they can watch, and we talk to them, a lot about, what they need in a solution. We also talk about what price as well these solutions are, because we supply some funding for the licenses and also the training and the migration of data in the first instance. But thinking long term, the license costs will have to be paid for by the providers. So we talk about how much these systems are, and we've developed a calculator tool, conscious that there are a lot of providers now on that assured supplier list from the NHS. So we need to make sure that they're making an informed, well-rounded decision about which solution they choose. We help them with procurement as well. So we help them set up the financial agreements, you know, as well as getting those quotes, and we help them set up the contracts and the payments to the providers. And then we help with the migration and the implementation. We support them with training, so we will pay for them some training to go live and some go live support. So it's a journey that we support all our providers on with a lot of tools that we've developed to help them on the way. So can we move on to the next slide, please? So we do work with the assured suppliers. So you know, new suppliers are coming on board all the time. When we first started out, there was just 4 or 5, but now, you know, we're up to 12. And it's about, you know, giving the opportunity for the providers to focus on the quality of the products out there. You know, so we give them a flavour of what these products actually do from all the different suppliers, you know, so that they are making that fully informed decision. As a team, we've met with each of these suppliers and we outline what our local programme offers. So we say, you know, what we will fund the licenses, we will fund some training and implementation support. We ask for the basic package prices because we don't pay for the full bells and whistles solutions. You know, we will provide a basic package for our providers. If providers want a bells and whistles, they can, you know, top up the price for that. And we need to make sure that those prices are locked in for future years. We've worked with suppliers to support open days, webinars and demos. And we've fielded requests from some of the suppliers because they said, oh, give us the names of the care homes that are on your programme and we'll contact them. Well, we didn't want that. We know how busy our care homes are. So we wanted, you know, our care homes to do the research and to just contact 1 or 2 of the providers that they were their preferred solution. And we provide monthly supplier updates and process guidance for all the providers in Lancashire and South Cumbria. So can we move on to the next slide, please? Now we keep our providers on track and we have a 5-stage process. You know, we keep in regular contact. We do that through Microsoft Teams, meetings, email updates, one-to-ones. We have a monthly checklist, you know, and we constantly try to make sure that our providers are engaged on their journey. You know, we will give them multiple opportunities to join, but when we feel like, you know, that they're missing out, they're not engaging like they should do, then we'll probably move them on to a later stage of the programme, because we want to work with providers who are really keen to work with us on that journey from paper to electronic care records. So we have a really thorough engagement process, and we keep track of where all our providers are on their journey, give them the prompts and the support that they need, but also recognise that sometimes things happen that, you know, they have to withdraw, they have to wait for a little while, you know, and rejoin the journey later on. So can we move on to the next slide, please? So I'm going to pass over to Nat now, who will talk about the community of learning and her work with us as part of our little team.
Thanks, Deb. So firstly, I just thought I'd give you a little background on how and why I became the subject matter expert for the team. So I am a registered manager of a residential care home, and I started the process of the funding application in June last year, and I've just recently implemented our electronic care plan system. So the transition from paper to digital takes a great amount of research, work and time, and I think setting achievable goals is vital. Once the system is fully implemented, the benefits are staggering. So although I would not consider myself an expert in anything, I offer to help others going through the process, which gives me a first-hand experience of what the providers will go through and hopefully help me ease any concerns the providers may have, as well as share my positive experiences. As part of our process, we give the tools to help make an informed decision, such as the decision tree that Deb referred to, and the cost calculator that was is amazing. It gives you all the prices from each supplier directly for your home. So as a team, we should make sure that the providers have all the information they need to choose the right system for their home, ensuring it meets all their needs. Throughout the process, we also offer one-to-one support for the providers that may be struggling for whatever reason. And that's when my role really comes into its own. We hold regular meetings with providers giving updates and sharing experiences and shared learning with one another. We have a monthly checklist that providers complete, so we know what stage they're at, and if they do need a little help to get them to the next stage. All providers have each of the team's contact details, and if they need tailored support, all they need to do is ask. As many providers have different levels of IT experience coming into the process, which we have found. We've had to do teams, training and things of that nature. We also are in the process of implementing a supplier-focused communities of practice, and we've chosen WhatsApp groups as our platform, as most people are already on WhatsApp. Once a provider has chosen their supplier, they will be asked if they want to join their chosen supplier WhatsApp group. The hope is the best practice ideas will be shared, and it's a space that the providers can bounce ideas and issues off one another, and it will be very much a provider-led group. Deb, back to you. Thank you.
Thanks, Nat. We move on to the next slide, please. So, what a difference, you know. So these are some of the things that our providers have said. So, you know, what one of them said, you know, that instant recording of care notes, staff now have time to have fun with residents, which in turn helps retain a fantastic staff team at a time when it's very much needed. You know, flags prompted care staff to refer to our dietitian, and that joined up approach to care giving across the team is now enabled timely interventions from appropriate team members, you know, where previously things could have been missed. And then somebody said in the previous role they'd used a digital system and they took it for granted, you know, and then when they came into this new role they wanted to have outstanding, you know, care and be able to see those assessments, care plans and notes side by side and in real time. So by moving from paper to digital, they've immediately switched on the lights and they've improved resident care plans and targeted interventions, and they now have a much greater insight which enables a more proactive approach to care. So it's really good that we do get these case studies back regularly, you know, where our providers have said, yeah, we love now the changes and the difference that moving from paper to electronic has achieved and helped. So can we move on to the next slide, please? These were just some pitfalls, hints and tips. Some things we've learned along the way. Negotiate, negotiate, negotiate. Now what we learned was our suppliers of these digital systems don't have straightforward costing. And, you know, they tweak their cost depending on who they're talking to. And, you know, you do have to go in and negotiate hard because you can get some good deals when you negotiate, you know. And I suppose when we started on the journey, we didn't appreciate that, you know, there wasn't a clear costing structure across all those suppliers. There was another one around the naivety around the actual cost of a digital social care record. So when we got our first 50,000, I think it was me in the instance said, oh, I bet we can support 20 care homes to go digital with that much money. What a fool I was. You know, it spread to 5 care homes, you know, that was. So there was no, you know, idea about how much these systems would cost. So we've learned a lot about that. We now know roughly how much one costs. And we did assume a lot of prior knowledge on the part of everyone, you know, not just our providers, but our suppliers and ourselves as a team. So we have learned an awful lot along the journey. The decision tree was another good one. It was perpetually germinating. We were promised it for months and months and months. Well, now we're glad to say it has sprouted and it is available, and our providers can look on the decision tree and it helps them make that informed decision. So if they want things like a family portal, if they want translations, those types of things, the decision tree helps them choose a solution that's right for them. We also noted a big digital immaturity of our providers. So some providers were way ahead on their digital journey. Others needed that extra support. So it's making sure that, you know, some providers don't need hand-holding, but others do. We've done a heat map of our providers, both one for care homes and also one for our domiciliary care sector. So we know which providers might need that extra support, and we're there on hand to help. Buying and lack of, you know, so we had a lot of providers approaching us saying yes, we're interested, and then they drop off. And we do appreciate, you know, that some providers, you know, COVID outbreaks still there, you know, they've got other pressures on. So, you know, we do know that some providers might be enthusiastic at the beginning, but then might drop off at the end. Guidance. So guidance for both the providers and the suppliers, that's been key. There's 42 of us ICSs all doing this, and we're all doing it quite differently. So it's really good to get your suppliers on board to know how you're delivering your programme locally, but also make sure your providers know what to expect. So we've got guidance documents for both sides of both our suppliers and our providers. We also had quite a lot of sour grapes from existing providers that had already gone digital, because they thought it wasn't fair that we were giving, you know, the money to some providers to move to digital when they'd already made that investment. So we've had to fend off a lot of sour grapes from some providers that took that initiative early. And yes, it doesn't seem fair, but those are the rules that, you know, we have to stick by. So we are only supporting those providers that are on a paper record that are wanting to move to digital. And there was this assumption that providers would just receive a check. You know, they say, oh, right, that's my system, that's it. Yeah, okay, there you go, there's the money. There's not. We've put in a very clear process that our providers have to move to and move with us on this journey. They don't just get a check. So for us, one of the key things is process, and then even more process. You know, make sure, you know, the process is clear, the process is well communicated, and everyone's following it. So I think, is that the last slide from me? It is, yes. Our contact details there. Both myself and Nat will be here for any questions at the end. But in the meantime, I'm going to hand over to Mark from the CQC.
Thank you very much, Deb. That was a really fascinating conversation. Often I'm talking at these events and I have to describe and not do justice to what you've just described. So that really makes my job a lot easier when I talk about the sort of thing that we are supporting. So thanks so much for the opportunity to talk here today. I'm Mark Sutton. I'm the Chief Digital Officer at the Care Quality Commission. And for those of you who don't know, we are the independent regulator of health and care in England. I love the title of this session, Creating the Clearest Picture, because for me, that is something really close to my heart and strikes at my role at the CQC. I think hopefully today I'm going to talk about a couple of things, and this is for me the opportunity to clear up a few misperceptions about CQC and digital. I'm going to talk today about our really strong support for data sharing, for digitalisation, for innovation in social care and across the system. And I'm going to also talk a little bit about how CQC is changing. So we are changing as an organisation. We are innovating through our use of technology and our use of data and insight to help improve what we do as a regulator. So firstly, I will talk about our support for data sharing across the system, and I'm really keen to set the record straight. There's often some misperceptions about CQC. I just to get in there first, I hear stories of people saying to me, you know, we only keep our paper records because that's for the CQC inspectors. I really couldn't strongly advocate enough our support for digital social care record systems and the innovation that digitalisation can bring to improve quality of services, and I think there's lots of reasons why we can advocate that support. Certainly the adoption of digitalisation is one of the ways in which our adult social care system can help cope with the growing demand faced against the limited resources that we have as a country, but it really is also something that we are the sector is demonstrating is improving the quality of life, is helping people to stay in their homes for longer. It is preventing unnecessary hospital admissions, as well as lots of all of the kind of intrinsic benefits that Deb, you described there through the work that providers that you've seen are doing. So specifically in terms of digital social care records, we know through the work that we've been doing over many years, the quality of good quality records really underpins safe, effective, compassionate and high quality care. They're really critically important to ensure that accurate information gets to the right people at the right time. And we know that digital records and digital systems far exceed those capabilities and the benefits of paper records. Deb and Nat, you described, I think, really beautifully there, the significant benefits that you've seen providers. And I love some of the particular examples that you gave there, down to the freeing up of time, helping residents have more fun. I mean, that's it's all about the quality of life and person-centered care. We see digital social care records helping minimize risk to people's safety. We see them supporting staff being able to respond more quickly to people's needs. We see them helping share information more quickly and safely, which are really important hygiene factors. And for providers, then it's not just about providing good care. For providers, they help them operate more efficiently. They help them give them management information and insight not possible with paper records. And I was struck by what you said there, Deb, about the unfairness of providers that have already adopted digital social care record systems. And of course, I suppose one slight offering you should give them there is, of course, they've had the benefit of digital social care records for a longer period of time, which is not insubstantial. And of course, there's lots of beyond just the hygiene factor of digital social care records. There are lots of other innovations in digital that providers are taking on. You talked there about falls prevention, but there are a huge number of other innovations, and it never stops, that are helping improve the quality of care for service users and their families as well. But beyond data sharing, data capture and data sharing that we get through digital social care records, there's another huge benefit beyond this as well. In our state of care report last year, we said that better data and data sharing are the critical components before providers can begin to address system-wide issues in a meaningful way. And we know, and it's been evident in the last couple of years through crisis in emergency care and delayed discharge, etc., that we know that there is such an integrated world of health and care. We can't really have a full picture of people's experience until we have data that enables us to see the full picture of joined up care across the whole system. And that's why this is increasingly important for us to be capturing and sharing data across the whole system. One of the things I'm keen to point out is, of course, that we are sympathetic to the challenges of adopting digital social care record systems. Ian talks at the top of this about look at the number of people that are here who have the capacity to be able to make change in a residential care organisation, and we fully appreciate that it can be daunting taking on change like this when you've got the day job to do. You're dealing with all sorts of issues such as COVID outbreaks and staff shortages, etc., and the pressures of continuing to provide services in challenging circumstances. So we're very empathetic to the challenge of us saying everybody needs to be adopting digital social care records. What I would say is, and I think you, Deb and Nat, you beautifully articulated it there, is now is the right time to do this, because now is the time that there is a significant amount of support available for adopting this, not just through things like the assured suppliers list, through financial support, but it's that implementation support as well, helping you move to a new way of working. And then I thought I'd just tell you a couple of minutes about CQC and our transformation journey and what we're doing. Our strategy is to focus on making sure that people and communities' voice is at the heart of what we do. Of course, safety is the core of our regulatory activity. We are attempting to try and accelerate improvements across health and care. But at the real heart of what we're doing in our current strategy is something we call smarter regulation. And that's something that we will be adopting this year. We are moving to something we call the single assessment framework, which is about attempting to try and drive a more consistent, transparent way of regulating and providing ratings and rating service out to the public and to the providers as well. And why are we doing this? We're doing this because we want to generate more up-to-date ratings, and those ratings that are both transparent for providers, but also that are much more meaningful for the public as well when they're making decisions about services. And this is something that we will start to implement this year in a careful rollout that we'll be working closely with providers to help make sure we build this in a way that is supportive of feedback that we get from providers. But it is something that we are doing. Hopefully, people will recognise that this is all about improving the service that we can offer to providers and to the public as well. And we will use data and insight capabilities to really help us focus our scarce resources on those areas where they are needed the most, much like your description of the digital social care records helping you spend more time with your residents and service users. This is about us removing the administration that we currently do from our inspectors so they can spend more time with providers, helping them to improve, helping to build those relationships. This is a consistent approach that we hope will be flexible and can respond to changes in the future. It'll be the same method that we use to roll out to support the assessment of ICSs and for local authorities over the course of the next year. And just a little bit on what our single assessment framework is. So the 5 key questions that we have: safe, effective, caring, responsive and well led will stay. But underneath that, we will have a set of what we call quality statements. And those quality statements underpin each of those. They're expressed as we statements that express what is needed to deliver high quality person-centered care. And for each of those quality statements, we'll gather evidence and rate those quality statements. And the intention is to reduce the impacts on providers, gather information more regularly. Observation of care will still be at the very heart of what we do, but we are keen to use data wherever we can to reduce the burden of data collection on providers. That's another reason why data sharing is so critically important. But this, particularly for adult social care providers, where they have had a rating that they've improved from, this will enable us to return quicker to providers to help re-rate them and evidence the improvements that they've made, which I know will be very welcome. And another important part of what we're doing is we will be providing information at a granular and transparent level that helps providers be able to see where they are in comparison with other providers, help them benchmark themselves against their peers to support more collaborative working. So all of this really should be seen through new digital services that we provide this year. We'll have new digital services for providers. We'll have new digital services for the public as well. What we will also be doing, again in tandem with that desire to want to minimise the burden on providers, is working with software providers and other parties to make sure that we can offer abilities to exchange information. There will be a new provider portal as a digital services for providers to use, but also the ability to integrate with provider back office systems as well. So I'm going to finish there, and I think I'm going to hand back to Ming.
Hi everyone, apologies I wasn't able to join at the beginning, but I just caught most of Rachel's presentation, so I'm really delighted to be here. I'm the Chief Data Analytics Officer for NHS England and have a particular interest in use of data and particularly for population health, and been working very closely with some ICSs. Just some reflections on the presentations that were given. I'm delighted that actually what we're focusing on now is use of digitalisation to make things better, both for the person, whether that's a patient, someone receiving care, or the administrative tasks that people need to do. And actually, Mark, even for CQC, how can we make life easier for regulators? I think this is a really positive feedback cycle. So patient needs and cares that Rachel's team really identified, and that's really important, making sure they're not acting as victims of the system, but actually have a voice and are able to articulate what they need and want, and how they want to see their records, and actually participate in their care. That then drives data that's required for service redesign, and a lot of what Deb and Natalie described are things that are helping us get with the digital care records. How do we then use that information to better drive both analytics and also use, and actually reduce the burden on day-to-day administrative activity? And then obviously that then creates an opportunity for improvement, which then, with CQC sitting in the centre of that kind of feedback cycle, can help us get better as well. From an NHS England perspective, and the work that we've been doing on population health, it's really important that we use data in a sensible way, but actually all the communications with individuals around how their data is used, how we're applying the opt-out so they have all the opportunity to understand and better use data is vital. But we're also using it for administrative processes to manage our flow. So we've got both a efficiency effectiveness drive, but also a safety and quality impact of use of data. And then from an ICS perspective and population health, we can only do this if we collaborate and share across the entirety of the system. Population health, why I'm excited about population health, is that it's not one size fits all. We actually use population health to really help support the demographics of the population of the place that we're trying to apply those situations. So, across the 42 ICSs, I'm very much expecting similar patterns of what could be done. How can you use the data to identify and target the need of the population? How we could then use that information to realign services to better improve those services and deliver more with the diminishing budgets that we've got. How do we do more with less? And how do we make sure that we target and kind of level up on inequalities as well, using that data to highlight where we've got issues that we should be targeting better, where people aren't coming forward because they don't have trust in the system, or actually they just don't understand what's available for them. So I think, Deb, some of the work that you guys have been doing is fantastic, working with the smaller providers. And I'm quite jealous because I think you might even get to digital landscape before the NHS, because you're actually doing it quite systematically and working with a variety of suppliers and actually helping. I think the first step always is to help people do their jobs better, because then they can enter the data, and then we can actually see what the importance of that is. I think all of this, in size and quality of this, and how we engage across the system is really important. But my reflection, and I always think about this as my role nationally, and how does that help? How does my role help local systems? And I think of this as kind of augmentation. So if you think about augmentation being, increasing the size, value, or quality of something through kind of joining up and really adding value to it, by synthesizing together as a collective, we can actually augment and create better value to the systems. So nationally, my role is to make sure we can help with some of the data sharing kind of contracts, data sharing arrangements, so that we can from a policy perspective, we can drive some of that. Where we hold national data, that should be made available for local systems, so you don't have to redo that. Making sure that we link and help work with the HSC so that it's not an solely NHS thing, that we are looking at across care, working very closely as partners with local authority. And I know we've got a long way to go for that. And part of that is allowing local systems to build that trust and development of those relationships. Because at the end of the day, this is a system approach, which is very much dependent on people wanting to collaborate and being able to trust each other to do the right thing. So I think I'm really enthused by this, all the presentations I've heard so far, and I think I'll leave it there and we'll take some questions. I think there've been some questions that have come through, and I'd like to kick off with maybe a question for Deb. From your experience, how can ICSs also work with small and large voluntary sector organisations along with the data sharing journey?
Well, unfortunately, the money from the NHS that we have had has been, earmarked, and it's been mandated that it only is for our regulated care providers. So the investment that we have had in digital social care records has only been for them so far. But we do have a digital social care group, and that isn't just for regulated care providers. That does include the voluntary and community sector. And on that group, we have representation from education, from health, from housing. We have a good representation across the board. And it is about supporting all our providers on the digital journey. And while we can't prime them with a digital social care record, because the money's not available to do that, we will help them if they do want to go on that journey. Conscious that we'll link them up and we'll get them on the roadmap for integration into a shared care record, and give them advice about open APIs and making sure that they are, investing in systems that can talk to each other, that don't need those complicated and expensive, links to be able to communicate. And we have put a number of our voluntary community sector organisations on our shared care record journey. So they're on the roadmap for integration. So the ideal is that we're all creating and consuming data in that shared care record. But unfortunately, the money's not there at the moment, but we've got our fingers crossed that once we've, cracked our regulated care market, the money can be move over to our voluntary community sector organisations and our non-regulated providers such as daycare organisations.
Thanks. And Ian and Mark, maybe there's something at the national level that we can do with the larger voluntary sector that are national, so that we can maybe work more systematically to help close the gap as well. I don't know, Ian, did you want to come in with any questions for the panel?
I'll just comment on that one thing, which is, yes, we are trying to work out responsibilities both nationally and locally, so that we get a clear view about accountability of what each person and each organisation needs to do. And you weren't at my initial opening, Ming, but the document that's been published this morning on cybersecurity has got to me some very good messages that we ought to adopt on data sharing. Which is trying to get ourselves to the point where there is trust and there are relationships and there is partnership working in its true sense. Because without that, I don't think we will get to the point where we reach out, not just the 26,000 registered services, but there's the 13,000 other social care services that aren't actually regulated, offering daycare and right the way through to housing providers as well. So we've got a very diverse sector. And we've got to make sure that the offering that we provide is appropriate to each part of that sector.
Thanks, Ian. I totally agree. Ian, let me just look at some more questions.
I was going to feed you one, Ming. So there's a good question about the national data opt-out and how the panel want to sort of talk about how people exercise their rights in relation to that.
So there is there is a policy, I think, that is made available on the NHS digital website for patients to actually look at in terms of how they apply through their GPs, etc. We're very clear, depending on the uses of data, how opt-out applies, and then down to the local level. And a lot of that is, you know, if it's direct care, it is the type 1s are applied at the GP practice and type 2s are applied nationally, which then gets carried through into all the situations where the data is being used. Not sure if there's any more information you need on that, Victoria.
No, thanks. We did have quite a few sort of at the beginning of the session, which were all about accessibility. I think Rachel talked about accessibility and the law and the National Health Service Information Governance Framework and the social care data sharing guidance. It might be really useful from Ian and your perspective, Ming, to talk a little bit more about those resources. We'll make them all available for people after this session, but there's quite a lot of different policies and guidance and how do providers pick their way through some of that and really understand what's really critical in terms of data sharing.
Yeah, so I think what we're trying to do is not one size fits all. So that's why when you look at the guidance, it looks really complicated. I think once you decide locally what's necessary, and I think, and Ian, please come in for the care providers. For the NHS, it's actually quite a established way of working, which is why I think that sometimes the conversations can get crossed. Because we're coming from a perspective where, you know, we have our CIROs, we have our DPOs, and, you know, all of those roles are actually established. For smaller organisations, we do need to have a better understanding and a discussion on how they apply for the smaller providers. Ian, did you want to come in on that?
I totally agree. I mean, I put all those sorts of things into the heading of infrastructure, and what infrastructure do we actually need at a local level? Because things like DPOs, we call them data protection champions, to actually say that everybody's got to have at least a basic level of who's taking responsibility. But Caldecott Guardians are another issue, where how do we actually enable people to have access to a Caldecott Guardian if they're such a small organisation that they don't want to and aren't large enough to actually warrant one? So data sharing agreements across an ICS, being able to actually work with GPs, with opticians, with dentists, all that sort of thing. We need to really bottom out what infrastructure is needed at that local level. At a national level, we're providing a website which is currently called digitalsocialcare.co.uk, which has got all the guidance on GDPR right the way through to the DSPT guidance, and a program called the Better Security, Better Care program that I manage, that's helping to actually provide local support organisations to help every care provider achieve the DSPT, if I'm not using too much jargon, Data Security and Protection Toolkit. So what we're trying to break down the infrastructure that we need into what should be provided nationally, what should be provided locally, and more than happy to have those conversations, Ming, over the next few months.
Yeah, no, I'm just taken, Deb, by the way that you've kind of cut it down and handheld locally. I think that's the model that we need to do more of, and if there's anything we can do to maybe push for a bit more money so that we can do more of that jointly, that would be great.
Absolutely, yeah. Yeah, I mean, we would love to extend our offer, you know, to more providers, but again, it is the restricted of money. You know, and when we first started on our journey, we just really did concentrate on care homes. And care homes, it's quite easy to do because you have a set number of beds. Now we're moving into a new territory where we're working with domiciliary care agencies that have bigger numbers of clients. Well, some of these suppliers charge per license per service user. You know, so you can imagine with a restricted budget and bigger providers coming on board now needing more money, it's like splitting, you know, 5 loaves and 2 fishes, you know, because that's the predicament we find ourselves in, you know. So we do want to work with more providers, some of the bigger providers, domiciliary care agencies, you know, but it's what we found as well is we have got in our first few tranches, you know, we did encourage those providers that were really keen to move to digital records. So we now found ourselves in the position where we've got our low-hanging fruit, and we're having to incentivise providers who are a little more reluctant to move on to that journey. So, you know, really some of those need a bigger cash incentive to move forward. You know, they need longer license, you know, a longer agreement for further license fees, you know, to instigate that change and to you know, encourage them to move on to that journey. You know, so at first it was really easy, they were dead keen. You know, now we're approaching those who are thinking, oh, but I've too much to do, it's too difficult, you know, and we're getting all the excuses now. Yeah. It's much harder now than it was at first.
So I think what I can do is take some of that back with our discussions with DHSC to see what we can do. Great.
And I think we also had a question about sharing the decision tree, which maybe Deb, we can also take away, because part of the learning network development is about bringing great ideas together and trying to build them out into something that other systems can use. So hopefully we'll be able to come back on that.
So the decision tree, it's a tool that has been created by the NHS. It's on the Digital Social Care, it's on the website, on Digital Social Care website, and it's not called a decision tree. That's what we call it, and that's what the NHS called it when they were developing. But if you have a look on the assured suppliers list, at the bottom of the list of all the 12 suppliers that are currently on the list, there's a link and it says, click here to search for a digital social care record that best suits your need. That is the decision tree, because that then gives you a series of questions that you answer, and it narrows down the 12 suppliers, so you're left with only the suppliers that are suited to you. So it filters out those that perhaps don't do text to speech, though, you know, there's some functionalities that some do over and above. Some do rostering, some do accountancy, you know, you might want those added functionalities in. So it filters them out for you, and that's what the decision tree is. But it's a publicly available tool for everyone on the Digital Social Care website.
Thank you. We've made that available in the chat. I just think it was your sour grapes and the whole decision tree. So maybe we need to give it a bit of symbology and then everybody'd probably start reading it in a bit more detail. Great suggestion. There were a couple of questions from Mark. One was about what providers might be able to expect from inspectors during a migratory process from paper to digital. And there was a second question as well around sort of the use of the information within a regulatory process. Again, I think there's also quite a lot of conversations going on about non-regulated services, and we'll certainly put some more information in the chat about non-CQC registered as we move forward.
Yeah, no, thanks for those questions. They're really good and quite exciting as well. So if I take the second one first, we've got the question that says, could we provide access to inspectors that sit and review care plans from their homes instead of now sitting in their home and reading care plans? I mean, that's possible now. So yes, if you've got a digital social care record, you can. Some of the software providers are innovating. They're all innovating, but some of them have facilities now for you to have a CQC inspector role on their system. So you just simply log in and they give you limited access to the things that you want to put in front of a CQC inspector. So already making it easy for you to be able to take advantage of digital social care record systems to support the inspection process. But that's just the start of things. So the exciting thing is where we can get to next with this. So with effective data sharing, that could come, you know, as soon as this year, we could be in a position where you, with control over your data and what you decide to share, have the ability to have, you know, more of a steady stream of data that's flowing into CQC, which means that, you know, we don't have to come and visit you to have these conversations about care records. We might have more of a relationship conversation with people about improvement, and, you know, recognizing the innovations that you're doing in your homes, and take that off the table. So that's almost a hygiene factor that we put to one side. I think that's really exciting because it shifts the conversation away from the things that, you know, might seem very not particularly not particularly value adding for us to be spending an awful lot of time on and getting to talk about the important things that you want to share. The transitionary period is an interesting one, because I think what we'd encourage providers to always think about is, of course, what the inspector is not looking at systems. They're not looking at they're not looking at the nature of the software systems that you're using. What they are interested in is what are the outcomes for service users. So they want to know that the care that you provide is safe, it's effective, it's caring, it's responsive, and it's well led. So I think as long as you bear that in mind as you go through your transition, and you focus on those things, and you're able to demonstrate those through that transitionary process, that's the important thing, because that's what inspectors are looking for. Yes, we will be empathetic, because we recognise that change of this nature is challenging, particularly for very small providers, which again is why we would link you back to the presentation from Deb and that earlier was absolutely wonderful. Look at the support that's on offer from ICSs, and the implementation is a really, really important thing for you to focus on. A good implementation of a software system is as important as the software system that you choose, and the support is there from ICSs. So we'd really encourage providers to take advantage of that.
Thanks, Mark. A
Thank
couple
you.
of really good other questions come in. One that talks about the digital care record linking across to the virtual ward and telecare, so that the clinician as well as the social care can feed into a holistic picture of the individual. I mean, some of our care providers within the Care Provider Alliance are doing some amazing things using AI technology and learning, and really doing some very innovative things and bringing those together. Maybe question for Rachel about sort of what the patient feels when there is proper linkage of data across the system to people.
Sorry, difficulty unmuting. Excuse me. This is all really interesting to listen to this, and what was coming up for me strongly while I was listening to all the questions and answers coming in was the need for that shared care. So we did a couple of surveys last year around shared decision making, and we did one with healthcare professionals as well to understand their views around shared decision making. And the barriers were there isn't this one record across the board, and to try and get that holistic picture of a whole person and be able to do what matters to that individual is so important. So I think sorry, it's just saying I'm on mute, but I don't think I am. Oh, that's good. It kept saying you need to unmute. So I think what patients tell us as the Patient Association is that they want access to one record that tells the whole story of their lives. So regardless of who they're seeing and who they're talking to, they're not starting again. And especially more of people with, long-term conditions or a multiple of different conditions, that they're not repeating themselves through the health and social care system.
Yeah, thanks, Rachel. And I suppose as we start to head into summary and wrap up, maybe the $1 million question is how this all gets funded. So there's lots of questions in the chat around grant funding for smaller organisations and making this sustainable for different providers, and the size and scale between NHS Trust, primary care and social care operators. So any thoughts from the panel about how we collectively fund, how we tackle some of this for the long term for sustainability?
I'll jump in on that one to start with, Victoria. I think the efficiency savings, we've got to be careful that we don't just look for efficiency savings in one part of the system. I'm going to use the example of proxy access to medication records, where when we implement that, we not only make savings from the care home's point of view, because they can see what lab tests have come back and what medication's actually been ordered and whether it's been ordered this month and all that sort of thing. But it actually stops the home sitting on the phone for an hour to the GP surgery asking to find out that same information. And there's a number of ways that we can make efficiency savings to the system as well as to different parts of the system. And somehow we've got to be able to justify the funding on that basis is what I'm basically trying to say. So there's efficiency savings within the dentist, the GP, the acute trust, whatever. But then does that make the service more efficient overall? And I think that's one of the things that we've got to try and wrestle with to see if we can justify to Treasury why some of these projects can bring multiple benefits across the system.
Yeah.
From my perspective, there's national funding available for your market oversight providers, so your big national providers are getting their money from a national team. Our local team are providing our smaller regulated care providers with the money to move from paper to electronic care records. And we've got to hit that 85% target within the next 12 months, so the money's there to get us to 85%. So, we're 15% short, plus our voluntary community sector and our non-regulated. So the money's there for 85%. Let's concentrate on the others that are going to need a little bit of extra cash and a little bit of extra support and convincing to move to digital social care records.
I think it's a pinch.
Sorry, I'm just going to reinforce that, Deb, that those voluntary and community service operators are usually the very smallest, and they're the ones that need the most support. Yeah. And that's the issue, that even for a larger organisation, they've got more capacity to implement these systems. The little guys haven't, and they're the ones that are going to cost us more money to support to get them to the same position on their journey.
Absolutely.
I think we're going to need to position the case based on the population need, and it's the little guys that are going to provide the little services that keep people out of hospital in a more tailored, personalized way. And therefore it's like the retail last mile, isn't it? How do you make sure you create a model that allows that to work, has a service which then has part of the service you digitalize? I think we've got to start thinking about this slightly differently, because it's what role those providers play, and how do we make the case that for them to be part of the journey to help keep people out of hospital or in their own homes. That's what we're trying to do, and that's kind of got to be the objective that we use for building the business case for more money. Okay, Victoria, was there anything else or are there any other questions that are coming through?
I think we'll let you come into summary and close if that's all right, just conscious of time now.
Yeah, so thank you everyone. I think that's been really helpful. In summary, I guess we all have a role to play in this, and really enabling national, local teams to work together so that the patients and the individuals are supported in the best way that they can be, making sure that we use what little bit of funding there is to accelerate that digital journey will improve data availability and data sharing, and therefore we can then start looking at some of the more smarter things to be more proactive around how we use that data. But initially we need to build those building blocks first, don't we, so that we can actually get some quick wins out of this. But also, for me, the most important thing is the relationships and the trust, and we can only do that if we start working together in little bite-sized chunks. By doing that, then we build that relationship, and then we're able to do a lot more. Then we can make the general case for more money and hopefully get that virtual cycle going. I wanted to thank all the speakers. Really apologise again for me being late, but this has been a really interesting and fantastic event. Thank you.
Any final reflections from Ian?
I'm quite happy to just reinforce 2 or 3 fundamental points, Victoria. Why are we doing this? Its effectiveness is my overall word, but that comes back to it's just as effective to make sure that we spend a small amount of money to keep somebody out of hospital or to keep somebody seeing a pharmacist rather than a GP. So we're looking at the efficiency of the system, we're looking at the efficiency of individual services, but primarily we're looking at effectiveness. How do we do it? Given the geographic and the organisational diversity of the adult social care sector, we've got to do some work nationally, but we've equally got to do an awful lot of work locally. And trying to identify what those responsibilities are and what those roles are at national level and at local level can be quite complex, but up for the challenge, and all the members of the Care Provider Alliance are more than happy to get involved in it in different ways. And sit around the table and actually try and come up with some solutions. Thanks very much, Ming.
Thanks, Ian. And thanks, everyone. Did you want us to mention the feedback form, Victoria?
I think that's been popped into the chat.
Okay.
We'll certainly write out to everybody that has registered today for the event. We hope that you've all found it useful. Some fantastic questions from our participants. The recording and the slides and useful links to all the different resources we've talked about will be available on the Care Provider Alliance website. They'll be available from early next week. And we very much look forward to welcoming you to another co-produced NHS England and Care Provider Alliance Learning Network session, hopefully in the not too distant future. We're aiming to probably have one late April or early May, but we'll certainly provide information to people about how to register for the next session. Thank you again to everybody. Thanks to all the participants and speakers. And thank you very much to our co-chairs, Ming Tang and Ian Turner.